Welcome to MD Insights. Today I have Rob Simon with us, and Rob is an HPB surgeon in DDSI, Digestive Disease and Surgery Institute. So Rob, what's an HPB surgeon?
That's a great question. So an HPB surgeon stands for hepatopancreaticobiliary surgeon, and we take care of diseases in the liver, bile duct, and pancreas mainly. They can be both benign, like pancreatitis, or malignant, such as various cancers.
Great. And today we're going to talk about chronic pancreatitis as a topic, because there are many areas in HPB surgery that we could talk about. But chronic pancreatitis is a disease that you take care of, I believe. And tell us what chronic pancreatitis is like for patients.
Chronic pancreatitis, it's a tough disease for sure. It's got a wide spectrum, but it stems from just chronic inflammation and irritation of the pancreas for a variety of reasons. But ultimately, it usually leads to chronic pain and can affect a lot of people's lives and on a day-to-day basis.
And just give us a sense, other than pain, of what other problems patients can have with chronic pancreatitis.
So other than pain, so two main functions of the pancreas are to make hormones. Most common one that people think of is insulin. And so some patients can have diabetes, such from that. Other function of the pancreas is it makes enzymes which drain into the intestines, help you digest food. And so sometimes patients can have what we call exocrine pancreatic insufficiency. Ultimately, they don't have enough enzymes that the pancreas makes. And so they have trouble digesting food, particularly greasy or fatty stuff. And so that can lead to not only malnutrition, but also bloating, pain after eating, as well as loose bowel movements that look greasy and float to the surface of the water.
So whenever you have these consequences, whether exocrine or endocrine, are those reversible by the time they have chronic pancreatitis?
Usually not, unfortunately. It's usually a process that is from the diseased pancreas being irritated for a long period of time. And it's not reversible, but it is treatable with medications such as insulin or medications, pills that they can take with eating to help replace and replenish their enzymes.
And I think it's interesting to note that even in surgeons who deal with pancreatitis, they don't always think of EPI or exocrine insufficiency. So you would agree it's important to really make sure you address that problem. Would you agree?
I agree wholeheartedly. I think, the first step in taking care of chronic pancreatitis is to ask these broad questions and take a thorough history and physical to really get a sense of all the issues that these patients are dealing with, because it can often be very complicated. And yes, nutrition and correcting these endocrine and exocrine deficiencies can often improve their quality of life significantly.
So I think the relative hospitalization rate of chronic pancreatitis hasn't changed much over the last couple of decades. But it does seem like the readmission rate seems to be higher in people who have alcohol as the cause. So it does perhaps highlight for us what are the causes of pancreatitis and how can we handle those?
So pancreatitis can be caused by a variety of things. As you alluded to, the alcohol is one of the leading causes of pancreatitis. And getting patients hooked up with a rehab program or resources to help them stop drinking can help reduce their inflammation and their irritation of their pancreas. Other causes of pancreatitis, the other most common one is gallstones. So stones that form in the gallbladder travel down into the duct and block the pancreatic duct can lead to pancreatitis as well. And then there's a whole host of medications that can cause pancreatitis. And so again, comes back to taking a thorough history to understand if there is some sort of medication that was recently added that can that could be stopped, hopefully reduce the pancreatitis. High triglycerides can also cause pancreatitis, so getting those under control is very important. And smoking can also contribute to pancreatitis and make that worse. And so again, educating patients on the impact of smoking on their pancreas and encouraging them to smoke and giving them resources is imperative to treating these patients.
Okay, and so the changes of chronic pancreatitis, I think you said, are irreversible. So how do you make the diagnosis? Is it always easy?
It's often quite the opposite. It's very difficult to make the diagnosis of chronic pancreatitis, but it basically comes down to imaging findings combined with history and using a combination of those to diagnose patients with pancreatitis. Diagnosing patients with the severity, because there's a variety of severities. It's a wide spectrum of a disease. And so, diagnosing patients with the severity is difficult to figure out where they are on that spectrum. But there's ways to do that with imaging and with endoscopy, where they can go down with a special scope, looking at their pancreas using an ultrasound probe through their stomach to, try and grade the pancreas and how much damage it has done.
So there's even a form of minimal change chronic pancreatitis where you don't see very much at all wrong. Is that true?
Yeah, correct.
Okay. But they still can have debilitating pain.
For sure.
So how do you decide who needs an operation before we decide which operation to do?
Yes. So that is the tricky part. And I think a big part of it comes down to multidisciplinary teams, such as the one that we have at the Cleveland Clinic, made up of gastroenterologists, surgeons, and radiologists alike, and psychologists and pain management doctors, because it all depends on how severe the patient's symptoms are. And we try and use surgery as a last resort. And when all other medical treatment has failed and the patients are really suffering, usually it's pain that causes them to seek surgical treatment. Okay.
And although you can't reverse some of the changes of chronic pancreatitis, even though it's the last resort, is it still good to intervene before people have more ongoing destruction, or can you predict that, or not, or if they're going to have more addiction problems to pain medication?
Yeah, it's definitely a fine line between optimizing them from a medical standpoint and a social standpoint and a psychologic standpoint. And not waiting too long for their pancreas to have too many changes. One of the things that we look at to help determine whether or not a patient is a good candidate for surgery for chronic pancreatitis is to try and differentiate their pain from pancreas-derived, or what we call visceral pain, to centralized pain. One way to think about it is kind of like phantom limb pain in a way, in the sense that patients don't have a leg anymore after it's been amputated, yet they still feel it. They still can have pain from that because it's a centralized sort of pain. And chronic pancreatitis patients can have that as well. And so operating on patients with centralized pain, oftentimes does not necessarily get their pain levels down and improve their quality of life significantly. And so using other modalities and other specialties to treat them is important, and trying to figure out which patients are best suited with surgery. But I agree completely. Trying to operate before it gets too late is one of the key parts in the decision-making process.
So do you have specialized techniques to try and figure out these centralized pain patients?
Yes, there's something that we utilize here called a differential pain block, where the pain management specialists at our institution use a variety of techniques where they numb the nerves that supply the pancreas. And they use varying levels of numbing medication, and they use a placebo as well to try and make sure that the patient's pain is reduced when they use the numbing medication. And that helps differentiate between centralized versus the visceral pain.
Okay, and you did comment that you often see patients in a multidisciplinary fashion. Do you think patients benefit a lot from that approach?
Oh, wholeheartedly. I think that patients really benefit from getting discussed and seeing lots of different specialties. Sometimes it can be seen as, them jumping through a lot of hoops, but I really do think that it allows us to make sure that we're operating on the right patient and that we're taking care of them appropriately.
So once you make a decision you want to operate, are there a lot of variety of choices in operations?
Yes, there's a lot of operations that we have at our armamentarium to help treat these patients. We can break it down into kind of two main categories. There's what we call drainage procedures and resection procedures. So drainage procedures are done when we see patients with chronic pancreatitis that have a big dilated pancreatic duct. And essentially what the drainage procedures do is they open up that duct and they bring up a loop of bowel and they sew it back to the loop of bowel, essentially acting as a blow-off valve so that pancreatic fluid can drain into the intestines and help decompress that duct. The other type of operation, the resection procedures, those are done if there's not a big dilated duct and lots of stone disease, or just even if there's no stone disease and they just have atrophy of the gland or they have chronic inflammation, the resection procedures are helpful in that situation. And those range from Whipple, where you take the head of the pancreas, part of the duodenum, and part of the bile duct, and sew everything back together. You can do a distal pancreatectomy where you take the end of the pancreas, or you can do a total pancreatectomy where you take the entire pancreas.
So you do occasionally do total pancreatectomies, right? And do you offer anything as an adjunct to that? Because that's pretty severe in terms of diabetes in particular.
Correct. So a few things, patients often ask me, well, can I live without my pancreas? I've heard that I can't live without my pancreas. And that is not true. You can live without your pancreas. It does come at a cost. Again, like we talked about earlier, the two main functions are insulin production and enzyme production. And so patients usually need insulin to help with their blood sugars and diabetes that they will get as a result. And they need enzymes to replace the pancreatic enzymes that they're not making for the rest of their life. But adjuncts that we do here is something that is called an auto-islet transplantation. So once we take the pancreas out of the body, we ship it off to a lab where they isolate out the islet cells. And what the islet cells are those hormone-producing cells that produce insulin. And then they ship it back in bags, and it looks like liquid. And if you look really close, you can see little teeny tiny cells that are the islet cells mixed in. And what we do then is we infuse that fluid and infuse those islet cells into the liver through one of the draining veins into the liver, where they then take home and hopefully help the patient manage their blood sugar control. What we kind of tell patients based off of our research and others is that a third of them become insulin independent, meaning they don't need any insulin because their islet cells, took home in the liver and are able to function well there. A third of patients need some insulin, but not too much, and it's pretty easy to control their diabetes. And then a third of the patients, it's like we did nothing, and they do need insulin, and it can be fairly tricky to control their diabetes. They're what we call a type 3C diabetic. And sometimes it can be a little trickier because they don't have some of the other regulatory hormones that the pancreas produces, and so they're very sensitive to insulin.
So is there a way to figure out which patient's going to end up in which third of those groups you mentioned?
We try and use various methods preoperatively to help. One that we use is if they're a diabetic beforehand. If they're a diabetic beforehand, then infusing islet cells is probably not going to help them too much because they don't have many islet cells to begin with. The other thing we do is what we call a mixed meal test. So we feed patients a meal and some carbohydrates and sugar, and then measure some lab values such as insulin and other insulin precursors to see how their body reacts, and use that as an adjunct to tell if they have adequate islet cell function in their pancreas.
And is it easy to decide who should get a total pancreatectomy with islets?
There is some subtlety to the decision-making process, but again, it's why we use our experts and the multidisciplinary team to make sure that we select the correct patients.
Okay, and in this day and age, looking at genes and all of those factors, do they play a role in chronic pancreatitis sometimes?
Yeah, they definitely do. There's been some genetic mutations that have been found that can predispose people to getting chronic pancreatitis, and so we use genetic testing not infrequently to help us determine the correct etiology of the patient's pancreatitis.
And in general, since the primary indication is pain, how do they do with the total pancreatectomy in terms of pain?
So again, if we select the right patients, they often do well. They're all hooked up with our pain management specialists, and it takes some time, but we're able to wean them off of a significant amount of their pain medications and get them functional again, get them back to a good quality of life. And again, it comes down to not only selecting the right patient, but one of the things I think we do well here too is patient education and patient expectations. And that preoperative education is vital to having the patients engaged and willing to work and get better.
And I know this is a form of transplant. Do patients need immunosuppression?
Good question. Patients ask that question a lot, and the answer is no, because it's their own islet cells. And so because of that, they don't need immunosuppression. Their body's not trying to fight off their own cells.
Great. Any thoughts you want to share with patients who may have chronic pancreatitis in terms of advice or ways to help them with or without surgery?
Yeah, I think the big thing is that there's hope, and that we have lots of tricks up our sleeves to help them and help them feel better and help them regain their quality of life.
Great. Well, thanks, Dr. Simon, for being with us on MD Insights. It was very educational, and I'm sure a lot of people appreciate it.
My pleasure. Thanks for having me.